there are models overseas that are used to scale up this sort of, care. Project Echo is one, a hub and spoke model. Have you considered that, where you start training up other clinicians around the country, particularly in regional areas, remote areas where access to care is, very difficult?
Certainly when any services reached out, we've been very quick to engage with them and to do that. I've certainly been met with a number of different health services in Australia and in New Zealand as well recently. The other thing that we've been investigating is potential use of a digital platform also to provide access. So the NHS in the UK has a great program called Your COVID Recovery, and we've attended some training sessions and met with the Department of Health around potentially employing something like that, which is it's an online platform. It looks like an app, and patients can enter their symptoms and monitor their symptoms. They can participate in a graded walking program, exercise program. They can access lots of resources, and they can also communicate with the health service as required. And so I think a great way of scaling our service up would actually be to triage the more mild symptoms into a program like that so that they can self-manage, and then the tertiary services can really focus their resources on where it's needed more in the severe disease.
Can I ask one more question, Chair? Just regarding return to work. How do you negotiate this with employers? Because it's quite challenging for some of these people. They've had a lot of people not validate their symptoms, a lot of sort of testimonial injustice, and how do you help them with that negotiation with their employers?
Yeah, I think that's a pretty good question, and I guess we've got the weight of the multidisciplinary clinic. I have no difficulty writing, the appropriate, and if I get stuck, I ask our liaison psychiatrist to help out as well. But I can imagine it would be much more difficult for an isolated GP to do that. And again, that might be something that your committee would think about. Someone with possibly tongue in cheek suggested there should be a post-COVID job seeker. But the notion that everybody gets better, but doing too much too quickly and not addressing issues is a roadblock.
Chair, I have a question regarding income loss, right? So a lot of these people are taking time off work. They may need help with childcare, particularly if they're women. And asking women, to rest is impossible. I don't know how you're actually achieving this, but can you talk us through what kind of measures what kind of financial supports we should be thinking about for these people?
There's a time limit, but my feeling is that in most cases there will be substantial improvement within 2 years. We're not looking at an NDIS like lifelong support, but yeah. I've got no doubt that there will be people who are permanently, inverted commas, scarred by their experience, because it's been, a terrifying existential, loss of control type of experience. But with careful management, that they substantially improve in terms of how they can live their lives, including return to work. But they need support.
So obviously, long COVID is enormously disruptive for children and families. And we know, at least for adults, that vaccination is protective. And yet we have in Australia vaccination rates in 5 to 15-year-olds sitting at around 50%, just above 50%. So can you just comment on, what we need to be doing with respect to vaccination? And and I'm also a little bit concerned that, at the start of the pandemic, COVID was discussed as being a mild infection in children. And I worry that this has, in the minds of a lot of parents, demoted the need for vaccination, when in fact, we now know that vaccination may well be protective.
And certainly that is the theme that is emerging from the international literature, that vaccination reduces your chances of developing long COVID. But yet at the same time, it is not entirely protective. So we would strongly support immunization according to the national guidelines for children, because as you say, it does reduce your chance of having acute COVID in children, which whilst it is not as severe as adults, it's still a viral infection and has rare complications.
So then to trace this backwards, vaccination would still be a very useful thing at a population level. At a population level, a small reduction in long COVID is going to translate to thousands and thousands of conditions prevented.
Yes, with regards to I guess that comes down to what proportion of children who have had vaccination are then protected against long COVID. And certainly the children who we've seen who have had long COVID often do follow a mild infection. Early on in the pandemic, we were seeing some children who had more severe disease prior to immunizations being available, and they also had post-COVID symptoms. But yes, I guess at a population level, when you consider that the immunization is likely to reduce your chances of having post-COVID complications through minimizing your risk of having a more significant initial illness, then yes, that would have a nice flow-on effect to reducing the population level of long COVID.
So I fully agree, prevention is better than the cure. I have so many questions to ask you, but I'll just fire away. With respect to vaccination, we have a fairly restrictive vaccination regime with respect to boosters, right? Now I know we're under with the third booster, but when it comes to the fourth booster, it's pretty heavily restricted, and I find the recommendations somewhat confusing. I've read them, and my background. I'm infectious diseases. I have a PhD, and I find it confusing to interpret those sorts of recommendations. Given the fact that we now have fewer restrictions on people's lives and repeated infections are almost certainly going to keep happening just with the cyclical nature of this infection, should we be rethinking our approach, our restrictions on booster vaccinations?
So I have a very pragmatic approach. So similarly with the COVID vaccine, I'd be taking probably a more what I'd call pragmatic approach to it. Of that, when people it's like many things. I often think if somebody asks me for something, they're asking me for a reason, and I believe that you provide it to them. So I would have that approach to vaccination, and I think rather than thinking about it in terms of the number of vaccines or the time, I think it's that gap between the likelihood of waning immunity and when we think we're getting our next wave. I think we should be taking sort of that sort of approach more. My view is err on the side of caution.
Yeah. So I'm hearing take a more pragmatic approach to vaccine availability. That's what I'm hearing, top line.
Yeah.
And
I would set the rules around it, Michelle, but I would take a far more pragmatic approach.
I agree. Okay, thank you, Margaret. And the other question I have is really a more, I guess, big picture one. We don't have limitless amounts of funding and money, Margaret, as you know. So if you were in charge of the pot of money, and given what you know about public health, where would you direct this?
If I was to say where I feel like we've not done as well as I would have hoped with COVID is what I would call community engagement and health promotion. So the way we've engaged with communities, particularly high-risk communities, I think could have been better. And the conversation with the public about what was going to happen, what was likely to happen, and what to do about it. So I actually think that, and people often think that that's the soft end. And if you're like saying, well, I've got some news for you, actually, it's the reality end. So my first area I would spend significant dollars is in explaining to people that COVID is not going away tomorrow. It doesn't have to overrule our lives, but there will be times when we need to be doing things, and we would like them to help us with this. And that might be to get vaccinated, to put on a mask and those things. So that would be where I'd be beginning to spend my first.
Could we be looking conceivably at training up, for example, a nurse with skills, where they're able to provide, say, a bit of OT, a bit of physio, a bit of some of the other allied health kind of interventions? Because I just can't see us being able to ramp up a workforce when we've got potentially 500,000 people currently with long COVID. And I'm interested to know whether there are some innovative options that we could be looking at now.
I think it's really hard to train up the nurses are under the pump as well. And to become sort of an OT, it's like a 4-year bachelor's degree. So I think it's really about thinking about maybe making better use of our allied health assistance workforce, because I think that works really well already in the acute services, especially on inpatient rehabilitation wards, where you might have an OT plan the therapy, but then the AHA does some of the more day-to-day implementation of that. And I think AHAs are really underused in Australia. I spent a lot of time in the UK where I often had an AHA or a therapy assistant, and they can be used really, really well. And the training for AHAs can be done through the TAFE system.
Is there any role for antivirals in preventing or mitigating against long COVID, even hypothetically? At the moment, antiviral access is pretty restricted in Australia for over 50s with risk factors, and yet the burden of disease for long COVID seems to be hitting people who are younger than that. So I just wanted to know if there was anything emerging in the literature around the use of antivirals.
So it's a really important question. I mean, both in terms of the mitigation and then even in terms of the potential therapeutic intervention for long COVID, given that some people are talking about persistence of infection. In terms of mitigation, you would hypothesize that if the antivirals reduce severe presentations, it should impact on long COVID prevalence. I haven't seen any data as yet that demonstrates that. I mean, the recent data in relation to molnupiravir is not too favourable in terms of hospitalisation, but it did shorten illness by 4 days. So still that hypothesis would be there that you could mitigate the risk of long COVID through antiviral therapeutic intervention. So
infection or illness. Again, this committee is obviously looking at long COVID, but also repeated infections. And I'm just touching on something Margaret Hellard said earlier, which is how do we measure success? And, success is also about boosting productivity of, the country, getting people back to work. And I think that's an important endpoint. So if we have an antiviral that's potentially shortening illness duration, making people get better faster, then is that something we should be considering?
Absolutely. If you can shorten illness, you can reduce the impact. If you also reduce the prevalence of long COVID, that would translate, you would imagine, into cost effectiveness.
I think I'm just interested, with this issue of waiting for more data. I mean, we kind of have to renovate the plane as we're flying it, and we can't wait forever. We've got a huge and mounting problem, and at a population level, it's significant, right? So I think, yes, we can all ask for the randomized clinical trial, but I'm thinking that we need to pull a handbrake now to kind of stop this mounting morbidity in people in their peak productive years. Just on the issue of the antivirals in the US, one of the antivirals is available from the age of 12 upwards. So a very different scenario to here, highly accessible to the population. Is there any data coming out of the US on long COVID in these people who are taking antivirals? And presumably this is a population which is highly exposed to this virus.
You're right. I mean, if we had data, presumably there'll be data in terms of long COVID service utilisation, post-antiviral in the younger age groups that will be really sort of valuable. So I imagine that'll come through.
It's really interesting because we give flu drugs, right, antivirals, for far less data, right? I mean, it shortens the disease by 1 day. Yeah, whereas if this is shortening the disease by 4 days, then that's something we should be looking at. I think it's really around implementation and embedding best practice. It's one thing to arrive at, creating all this knowledge, which is great and important, and then putting it into a guideline. But just because we write a guideline doesn't mean that any of that gets actually implemented at the coalface, right? So I think this is where we fall down in medical research in general, that we're very good at producing knowledge. We're very, very, very bad at actually embedding it at the coalface. And with respect to GPs, I fully agree with you that we do need to support our GPs, but just saying education alone is not going to fix this, because they're time poor. They have a lot of other competing demands, and I do think that if we're going to be talking about funding research, then we should also be talking about how do we fund implementation research that actually takes all this knowledge you've created and embeds it at the coalface so that we're actually changing and helping patients.
Yeah, we couldn't agree more. So, I think, closing that loop is absolutely essential, right? So I guess, we've been talking about the, understanding how best to implement this work and, where the gaps are in terms of implementing any sort of systematic management plan or assessment is an absolutely essential part of making sure this all comes together.